Cardiologists agree on one universal truth. Intense physical exertion is the cornerstone of cardiovascular health. Regular exercise strengthens the heart and mitigates systemic risks like hypertension. However, in an athlete harboring a silent aortic aneurysm, the same exertion pushes a compromised vessel wall toward its mechanical breaking point. An aneurysm is a focal dilation where the vessel expands more than 50% beyond its normal diameter. It remains asymptomatic, quietly stretching the tissue until the moment of rupture. This forces sports cardiologists to weigh the systemic benefits of activity against the acute risk of vessel failure, a decision that requires an exact understanding of how specific movements load the aortic wall. Resolving this tension requires a synthesis of molecular pathology and hemodynamic stress, determining whether a patient's biology can withstand the physics of their sport. To understand why an aorta fails, we have to look at the biology. Abdominal and thoracic aortic aneurysms are distinct pathologies that require completely different clinical frameworks. Abdominal aortic aneurysms, or AAA, are inflammatory diseases driven by atherosclerosis. An overactive immune system sends macrophages to infiltrate the vessel wall, releasing enzymes that dismantle the tightly woven elastin and collagen matrix. Thoracic aortic aneurysms are often genetically encoded. Conditions like Marfan syndrome disrupt the microfibrillar network, causing the medial tissue to inherently degrade and structurally fail. A third vulnerability bridges both of these diseases: the failure of the vasa vasorum. This is an intricate network of tiny microvessels embedded in the outside of the aorta, responsible for feeding oxygen to the thick medial wall. Microclots can form within these tiny vessels, severing the blood supply. This starves the aortic wall of oxygen, causing widespread cell death and mechanical brittleness. Before an athlete even begins their workout, their biological matrix may already be compromised from both its inner and outer surfaces. Heavy resistance training involves intense muscular contractions, paired with the Valsalva maneuver, a forced exhalation against a closed glottis. While absolute arterial pressure can spike during a lift, the concurrent rise in intrathoracic pressure acts as an external counterpressure, actually shielding the aorta during the strain phase. The mechanical danger arrives with the sudden release of that strain. This creates a violent impedance shift, a backward pressure wave that slams into the ascending aorta and can trigger an intimal tear. Endurance sports like rowing or running present a different load. Instead of an acute pressure spike, the system processes a massive continuous volume of blood. This chart shows that during moderate aerobic effort, peak aortic wall stress remains roughly 70% below the rupture threshold. However, a diseased aorta is less efficient. It absorbs 30% more stress per unit of blood flow, meaning the tissue fatigues faster. A compromised aorta can often process continuous volume safely, but it remains highly susceptible to sudden impedance shifts. Years of high-level training naturally cause the great vessel to adapt. This physiological remodeling is known as the athlete's aorta. This creates a diagnostic challenge. Over 20% of master endurance athletes have aortic dimensions that exceed standard population maximums. To find the truth, physicians use indexing. By scaling the vessel size to the athlete's body surface area, a supposedly enlarged 42mm diameter can normalize into a safe Z-score. Without this mathematical scaling, physicians risk either banning a healthy athlete or clearing a patient with silent active pathology. Modern cardiology has moved toward shared decision-making, replacing blanket bans with individualized physiological thresholds. Patients cleared for activity must stay within strict ceilings: resting blood pressure under 160, resistance training capped at 50% of their maximum, and an absolute ban on the Valsalva maneuver. Recognizing a failure in progress is equally critical. Signs include abrupt tearing chest pain, or unexplained fainting or pulse loss in one limb. These symptoms demand immediate cessation of activity and emergent pharmacological treatment to reduce the force of the blood hitting the vessel wall. Patients who maintain a baseline of fitness show significantly lower blood pressure spikes during exertion, proving that intelligent prescribed exercise actually stabilizes the mechanical system.